I will talk and research in uveitis, my journey and way forward. I'd like to thank Dr. Somushila and AIOS for giving me this opportunity. I'd like to share my humble experience. It was in 1985, I joined as a consultant, finishing my vitreoretinal fellowship. I was given a research project, ocular morbidity in tuberculosis. Questions we asked that time, what is the ocular morbidity in active systemic tuberculosis? What are the various types of ocular tuberculosis seen? Is Eales disease seen in active systemic tuberculosis? I went to the Tuberculosis Research Center, made a makeshift ophthalmology clinic, and spent 1 year there seeing 1,500 patients of tuberculosis, active systemic tuberculosis. My finding, only 14 cases we found, and this is 1.39% was ocular morbidity. Most common was field focal choroiditis, and interestingly, no case of Eales disease was seen in this cohort. So this is the case of miliary tubercle of the choroid, which you have seen, and this photo was taken 36 years back. I was not sure about my findings because those days, the electronic literature search was not there. I did extensive manual search of the literature. I found my observation was correct. There was a TV sanatorium. They observed almost the similar findings. This was published in International Ophthalmology, Ocular Morbidity in Patients with Active Systemic Tuberculosis. Then I started looking for the TB in Path Lab registry, and there are only 5 cases where bugs are seen in 10-year period. 2 cases of subretinal abscess, 1 case of granulomatous uveitis with scleral perforation, 1 case of exudative mass in the anterior chamber, another case of choroidal mass with panuveitis. Only 5 cases in 10 years span, and we published in the Retina Journal. And this was one of the cases where we found subretinal abscess with retinal hemorrhage. The patient was put on antitubercular treatment and steroid. In spite of that, the patient went for panophthalmitis, and then we need to do the evisceration. Eviscerated tissues, we are surprised to see myriads of acid bacilli in the subretinal space. We used to see a lot of Eales disease patients. Now we don't see. There are 1 in every 135 eye patients in the Shankarnetrale was Eales disease patient. So we asked the question, is the MTB there in the vitreous fluid? Many ophthalmologists, stalwart ophthalmologists used to think that the Eales disease is due to the TB. We want to have a definite proof of that. We got the vitreous fluid epiretinal membrane from the patient of Eales disease who are undergoing vitreoretinal surgery. We did smear, culture, and polymerase chain reaction. I worked with Professor Madhavan, microbiology department, for about 1 year, and we found that about 50% patients of the vitreous specimen was positive for mycobacterium tuberculosis DNA. However, culture was negative for MTB in all cases. This was published in British Journal of Ophthalmology. Subsequently, we looked in the epiretinal membrane for mycobacterium tuberculosis DNA, and we found 47% of the epiretinal membrane in Eales disease contains mycobacterium tuberculosis DNA. And this is the agar gel photograph showing positive mycobacterium DNA amplification. We concluded the cell-mediated immunological reaction triggered by sequestered mycobacterium tuberculosis DNA or antigen plays important role in pathogenesis of Eales disease. We indeed found a mycobacterium tuberculosis DNA with nested PCR in an enucleated eyeball of Eales disease patient. We compiled our data and gone through that 300 full text article and wrote a major review, which are often quoted in the literature in survey of ophthalmology. We didn't stop there. We looked into our outcome of large cohort of patients with Eales disease. We studied 500 patients, 898 eyes, with 15.8 years mean follow-up, ranging from 10 to 25 years. We found bilaterality in 81% cases. And acute stage is the oral steroid, which provided better prognosis, laser treatment in the proliferative stage, and recurrence were not uncommon. 52% had less than 5 recurrence in 10 years period of time. We later on looked into the other aspect of the diseases, which I wanted to mention is the AIDS. Ocular lesions in AIDS, we are the first to report 2 cases of AIDS with ocular lesions. And subsequently, we studied 100 consecutive patients of AIDS ocular HIV infections, lesions associated with HIV infection. And we went to an AIDS care center And we found 40% patients had one or more ocular lesions that time. And this was published in American Journal of Ophthalmology. We looked in specifically ocular tuberculosis in acquired immunodeficiency syndrome, and we found 4.8% of the HIV patients has ocular tuberculosis. And it has got a protein manifestation starting from the small tubercle in the choroid to panophthalmitis. In the epidemiology of the uveitis, I had a humble beginning, and I used to get meticulous record of all uveitis cases by hand in register, writing it. I analyzed it when I had completed 1 year and wrote it up, published, and often cited in the literature, one of the first publication of pattern of uveitis in India. It was Dr. Devashish Das who compiled the data, and we found anterior uveitis is the most common, followed by the posterior uveitis, then intermediate uveitis, and pan-uveitis. We studied that 23 years after, looked into the pattern of uveitis, what has changed occurred. We found the etiology was determined in more cases, like 66%, what is 41%. Intermediate uveitis was the second most common, unlike posterior uveitis in the previous series. Most common cause of posterior uveitis changed from toxoplasmosis to tuberculosis. It was a significant finding. We also found viral retinitis and increased from 0.76% to 6.8%. What I wanted to express that is that you need to follow your data and you can learn a lot. We had a chance to do while doing the glossing donor eye as a pathologist, I saw retinal hemorrhages in the eyeball of a patient, very peculiar. So we got that patient had malaria infection, and I got another case from the laboratory records. I wrote it up with the finding. Not only that, I looked into the very diligently all the sections in the parasite, all the paraffin sections of the malaria case, and I found indeed malaria parasite within the choroidal blood vessels. And this was published in the Ophthalmology Journal. What I feel is that when you want something, sometimes somewhere all the universe conspires in helping you to achieve it. So we also published in parasitic uveitis like intraocular Gnathostoma spinogerum, 2 cases. Many of us seen parasite in the eye, but I took it and I documented the case and then took to the botany department of Madras University for electron microscopy. And this was the first time that electron microscopy was done. It was a well-documented case, not only showing the anterior chamber infestation of the parasite, but also the crack which the parasite has produced, and also the parasite in the vitreous cavity, as well as the membranes inside the vitreous cavity. This is a weight mount preparation of the parasite and the scanning electron microscopy and histopathology of the photograph of the parasite. The most turning point, the most important turning point in my academic career is my fellowship in ophthalmic pathology, which I was fortunate to work under Professor Narsingh Rao between 1987 to 1989, which opened the horizon of my outlook in the academic world. I had learned a lot from him, and I started working in the pathology of the uveitis, biopsy pathology of the uveitis, and seen on the cases like pseudohypopian, lens-induced uveitis, large cell lymphoma. So my work could not have been, journey would not be possible without the help of my mentor, beloved chief, Dr. Badrinath, S.S. Badrinath, and my other mentor, Professor Narsingh Rao from Doheny Eye Institute, University of Southern California, and a lot of others whom I have got privilege to work with it. Some of them are fellows and some of them are consultants. Of course, my teammates, which has helped us a lot. I will never forget my photographer, Professor Mr. S.P. Govindarajan, who diligently worked for me and helped me a lot to document the cases. And last but not the least, my wife who tolerated me and long hours of my work. And in fact, she helped me in writing my first international publication, Primary Non-Familial Amyloidosis of the Vitreous. I remember I was so passionate about it. I wrote 7 pages. Reviewer asked me to write it within the 1 page. I simply couldn't do it. I was so attached to the article. My wife cut it off and put it in the 1 page, and it got published. Now I like to share my thoughts and publications in peer-reviewed journals. I there is an adage that publish or perish. I say that it's a publish and prosper. I believe that a scientific work, no matter how spectacular the findings are, is not complete until it is published. The scientist must not only do research, but also must write up the research works to communicate with others. So what is required? Enthusiasm, persistence, strong commitment, and last but not the least is passion for it. Why you do it? What is in it for you? It's aged in history, persist forever. Publication is the gold standard of the research, learning from the literature review, learning from the review process which you get, and knowledge get crystallized in the process. I started the baby steps. First wrote in the House Journal of Netrala Insight, then in Tamil Nadu Ophthalmic Journal, and I'm still learning in spite of writing in several peer-reviewed journals, PubMed Index. This is the journal which I published my first article, Netrala Insight. And then subsequently with the knowledge and all, I could write a practical suggestion in the writing of a research paper. The way forward, I like to share my view. What I'm doing now is ASOCTA, retinal vasculitis and choroiditis, metabolic biomarkers in uveitis with the help of the genetics department and biochemistry department, metagenomic deep sequencing in intraocular fluid in uveitis with the help of our molecular biology department, and with the rheumatologist help, I was trying to do that. I'm trying to do the new biologics in uveitis. This is a ASOCTA picture of an Eels disease patient showing elegantly neovascularization of the retina. I am also trying to correlate with multimodal imaging with ASOCTA, and you can see the flow void areas in the bottom, and this which disappears after the treatment with the immunosuppressive treatment. And these are the cases of that of autofluorescence, fluorescent angiogram, ICG, and OCT. So what I feel that we need to collaborate more. National and international collaborative research work is needed today. Analysis of the big data, artificial intelligence, proteomics in uveitis, metabolic biomarkers, new imaging technique, next generation sequencing, and targeted and local therapy. And many of us are doing it. I'm quite happy. Artificial intelligence and deep learning in ophthalmology will come in big way in the coming years. And there is some of the markers we can find out probably like an MYD88L265 mutations in intraocular lymphoma, which we have worked it out with a sensitivity of 88.9%, specificity of 91.6%. Some of the new markers we might find it non-infectious or non-infectious uveitis. Some of us doing the protein biomarkers in uveitis, or animal models of some uveitic entity which can provide us a diagnosis and treatment for the uveitis prevalent in our country. And the metagenomic deep sequencing, which can identify the common and rare pathogens which are not aware of, many in uveitis, which can be new vista of diagnosis. So other way is to looking into that one, revising the diagnosis by peripheral blood transcriptomic and whole genome sequencing, which would come in the patients with infectious or non-infectious uveitis. So I like to end my talk with a quotation from T.H. Huxley: "The known is finite, the unknown is infinite. Intellectually, we stand on an islet in the midst of ocean of inexplicability. Our business in every generation is to reclaim a little more land." And this is the duty of all of us. And the way forward is this. Thank you very much.